Hey everyone, it's me, Dr. E, Dr. Ellen Fitzenreiter, we're talking about addendums today with Rebecca Walter, who is I'm going to let her talk a little bit more about herself, but today we're specifically focusing on addendums and why to do them and when to do them and how to do them.
My name is Becky Walters. I am Rebecca also. I have a medical compliance specialist certification, which is a national certification regarding not only documentation, but other federal regulations. Plus, I have about 30 plus years of experience running a Virginia office. Many of you would know my husband, Greg Walter, who's past president of the VCA and ACA delegate and blah, blah, blah. So who has now semi-retired, but I'm still working. I did also work some for KMC University for several years, speaking at different events and performing audits. I have performed hundreds of medical records audits. Most recently, I was working for a short-term time with Carilion Clinic, helping them get documentation going in Epic for their therapies and cath lab and the radiology department. So lots of tech experience, loads of medical records experience and auditing experience. So that's what I come here to share today.
Great, great. And so you know a lot about chiropractic, and then you've also done other things, other healthcare providers. So, okay, great. Well, let's see. So addendums are, so when a signed note is opened, information is added and the note is re-signed. So it changes, I guess this should have been the second slide, but yes, this changes the date. So when to do an addendum: when a required element of documentation is missing from your notes. And so, Becky, if you can give an idea of maybe what some oversights might be that a doc might find out about.
Yeah, generally, you don't review every note every time after you go through it and create it on that day. That would be too laborious. And so either you hopefully have a planned time to review some sample notes, or if you don't, it's when you get that request, right? You get the request and you start looking and you realize a couple of things, and you can do an addendum, a simple addendum, when facts are obviously erroneous inside the documentation. And some good examples are, let's say you've got orientation wrong, like it's obviously everything, all the symptoms are on the right side, but somehow in your testing procedures, you recorded a left straight, right, leg raiser, excuse me. For example, that would be something you could obviously say, this is a human error, and it's obviously right when I said left. You may even be able to do that with a lack of diagnosis. If you have full support for a specific diagnosis in your exam and in your complaints, you have an OPPQRST, and you have everything documented for your for a specific diagnosis, but you omitted it by accident from your diagnosis set, that may also be something. Facts are obviously in evidence. What you can't do is create facts that are not someplace in evidence. And so that's why addendums can be helpful, but they are also often seen as a suspect from a reviewer to wonder, did you create documentation when you received the request and it was not there before? So that's what you have to always keep in mind if you are choosing to add an addendum to your medical records. That makes sense.
So that was actually interesting, because as somebody who has survived an audit, and I'm still fighting certain elements of it, is diagnosis, and that's a common thing to get denied, at least with the docs who were in prepayment review last year in Anthem here in Virginia, is they said the diagnosis didn't support what you were doing. So if your exam findings and intake, you mentioned earlier today when we practiced about the intake, if that supports adding a diagnosis, you can do that. How can you explain that a little bit more?
Well, so let's say, and I can think of an example. Let's say on intake you have history, and it shows a history of osteoarthritis or treatment for such, or some other underlying disease that was in the medical record that would create a degenerative situation, obviously. And let's say that in your exam, and what I find a lot is that a lot of docs, unfortunately, you're doing this great exam, but you're not writing down enough of the elements, right? And so if you just have enough written down in there, but you failed to document some kind of degenerative process, and all you're documenting is, let's say, spasm or pain, which are very, very short-term care situations, and that's often why they deny due to documentation. If that's the case, but you have the supporting, both in some kind of written document the patient supplied, perhaps it's copies of notes from another provider, or it is, just their history, you may be able to support, well, maybe it's an old x-ray report that has degenerative changes. You could support a degenerative diagnosis. The problem with that is, and here's the caveat, if you have multiple days past when you should have realized by looking at your records that, oh, I didn't address this degenerative disease, this may not be taken very well, because if you've got 16 visits on pain, they would expect you to at least have seen it somewhere along the line, and to say at that point, make an addendum, oh my goodness, I didn't do this, and then carry it forward properly for the rest of the time. So there is a bit of it's a challenge there if you go back and find it, but certain small ones you can do.
Okay. All right. So, and then how would a doc? I guess something that comes to my mind is going to a workshop. You go to a great training about documentation because you're trying to do due diligence to make sure you're doing this correctly. And in the workshop, you realize, oh my gosh, I am not doing this thing that I know I need to be doing. So that's one way to know that something is missing. And then another one is if you do have a professional look at your notes, if you want to have that more focused look specifically on your own files by somebody. So a workshop or seminar, actually getting your guidelines. And I talk to docs all the time, and 99% of the time they don't know what their guidelines are for their carriers, and that's a problem because you can't say what they want you to say without you knowing what that is. And even at our recent convention, a doc raised her hand and she goes, well, if they just would tell us what they want, and they do, that's what this is. And you have to know to ask for them if you haven't read them, and then once you know your guidelines, then you know what has to be in your notes, and then reaching out to a pro.
Yeah, you do need to. I talk all the time about self-auditing and knowing what you're auditing for. And you're exactly right. There are medical review policies. All the carriers have them. They may not make them easy for you to find, quite frankly. For ERISA plans, maybe they have a summary plan description. So you have to medical review policy for general carriers, summary plan descriptions for those who are self-insured. You have, for Medicare, it's an LCD, local coverage determination. So you kind of have to know the lingo or reach out to someone who does. And once you do, create a file of those so that you can then look at your documentation and do it at the most common denominator, the highest level. You generally, if you document to your highest level across the board, you don't ever have to be concerned. If Blue Cross has a more restrictive signature policy, which they do, then you should set all your signatures to be the same so you don't have to worry about it. No one cares if you do more, usually. They do care if you do less.
Sure.
And getting someone to look at it who knows. Just because you may still be in doubt, and it's right to get someone who's trained as I am, has a certification, to look at it for you.
Sure. And in your experience, when a doc calls you, it's usually because they're being audited? How many docs just sort of proactively reach out?
Once in a great while, someone gets frightened because other doctors that they know have been audited, and they will be proactive and reach out. And that's the best of all, because we can draw a line in the sand. We can't go back and fix that old stuff, really. I mean, unless you have the paper documentation that helps you support an addendum with more facts, which sometimes you do. But if you have some kind of therapy records or things, those paper documentations can be referenced in your addendum. But if you don't have that, then you can't go backward, but you can draw a line, and that really does help. If you get audited on a past one and you have drawn the line in between and improved your documentation, usually they will look at the documentation that you do now, and decide whether you still need to be in some kind of improvement or under review or prepayment situation or whatever. If you've already improved it, it saves you some headaches.
Sure. And I would add that some audits are more aggressive or assertive than others. And I can speak for the docs who were audited by Anthem last year, like I was, and they were taking no prisoners. I'll put it that way.
Anthem is not, they don't have a prisoner cell.
There you go. It
Yeah.
was awful. And I will also add, so if you're a doc listening to this, whether or not you should have a professional look at your notes before you get audited, or well, I'll wait, if I get a letter, I'll worry about it then. I will tell you that if you're in audit, especially once you get in prepayment review, you do not want to be fixing your notes while you're not getting paid and you're going through your reports. To be proactive and take care of this before it's a problem is crucial, because otherwise you will be at your office at midnight.
Later.
Yeah, or later,
Mhm.
or go under. And both Becky and I know docs who lost everything because they got trapped in um, trying to get this all done and not knowing how to do it. You need to be proactive. All right, so we covered when to need to file review and what, and carrier dependent. So right now is if you want to talk to Becky about files that you've got, here's her contact information. And I I guess you have this actually is on my blog, which anybody anywhere can be seeing, but you are the insurance specialist for the Unified Virginia Chiropractic Association, and you have a special pricing for UVCA members. And if you want to chat a little bit about for a single file review, if you could chat a little bit
And a
about that.
single file review is really appropriate when you get an audit,
Hmm.
and not necessarily 3 chart. And I think we've said that. And for anyone not in the UVCA who may be listening to this, I charge $150 for a chart, and for UVCA members, I reduce that to $100,
Hmm.
and that it will include a review and talking about the coding as well. We're just talking documentation here, but
Yes,
CPT coding also drives your documentation. Did you document to the code? Were you able to really support that billing? Did you bill appropriately? Let's see what's going on here. Did you use correct modifiers? That's what that $100 is for, to see if for
sure.
that patient, that chart, you met the standard for what you're doing. You've learned a lot, haven't you?
Okay. Yes. And and a lot of it is just communicating with people and sharing stories, because docs don't like to talk about being audited. And in fact, I used to post in the listserv and they'd say, well, if you did this right, you wouldn't have. I was like, you have no idea what it is like going through this. And people would reach out to me privately, but they were embarrassed. And it's like, we need to stop taking that embarrassment out, because what happens is docs keep information to themselves and we can't share that and reach out to our association or our specialists or our larger associations and do something. When carriers do something wrong and they're getting away with it, they're getting away with it because no one is doing anything about it. So that's what I'm trying to do.
Thank you for doing that, because it's important. Most people, when I say I'm certified in compliance, don't know what that means, and that makes me sad, not for me, but for them, because compliance is just not just a bunch of regulations that are somewhere in the Federal Register, although it does do that. It's day to day. Let's keep my practice going. Let me sleep at night. Let me keep my staff and understand that how important they are, and be able to provide this care to the patients who rely on chiropractic so heavily to make their lives better. And that's my whole life's work has been that.